Welcome to the Veterinary Rehabilitation Podcast, where we aim to help fellow veterinary rehab therapists increase their knowledge and elevate their practice. I'm Megan Kelly.
And I'm Anae Lloyd. Together, we bring you the latest insights, research, and information in the field of veterinary rehabilitation.
This podcast is brought to you by Onlinepethealth, a leading continuing education membership for veterinary rehabilitation therapists. With Onlinepethealth, you'll have access to a wide range of online resources to help you stay up to date with the latest techniques, advances, and trends in the industry.
Our podcast features in-depth conversations with leading experts in veterinary rehabilitation. They share their own experiences and knowledge to help you improve your practice. Whether you're a seasoned pro or just starting out in the field, our goal is to provide you with the tools and the insights you need to succeed.
So join us as we explore the exciting world of veterinary rehabilitation and help you take your practice to the next level. Hey vet rehabbers, Narda from CuraCore Vet joins Anae today to go through the research on the conservative management of IVDD in canines. They discuss papers that have reported on conservative management, rehabilitation, and electroacupuncture, discussing prognosis, rates of recurrence, rehabilitation practices, and so much more. The study on electroacupuncture was particularly interesting as the patients included in the study were all Dachshunds with no deep pain sensation who started treatment after 48 hours from injury. Surgical decompression was compared to electroacupuncture and surgery followed by electroacupuncture. They emphasized that we need to offer owners better options for the treatment pathways available for them and their dogs, and what is the standard of care and should we be challenging it? Now, there are 18 days to go until the Vet Rehab Summit. This is our annual online veterinary rehabilitation conference, and this year we are focusing on the ethical challenges we face as vet rehabbers. So I would like to ask you to come and join us, please, as we explore all the specific ethical challenges, how we find our personal and professional ethical boundaries on these issues, and how we can bring change through education and increasing awareness on the ethical issues that we are most passionate about. Now, tickets for the event on the 31st of August are available at vetrehabsummit.com. Online Pet Health members, you get free VIP access to the Vet Rehab Summit. We have paid full access tickets as well as free limited access tickets where you get to access one of the live webinars on the day, and it's called Placebo Treatments in Evidence-Based Practice, Ethical or Not Ethical. So if you are not an Online Pet Health member, those are the other options to you. If you're listening to this after the date, you can access all the Vet Rehab Summit recordings in your Online Pet Health membership. Now, our podcast sponsor is Narda Robinson herself. She first developed her courses at the Colorado State University, where she started the Medical Acupuncture for Veterinarian Certificate program in 1998. In so doing, Dr. Robinson developed a science-based platform for veterinary acupuncture, the first of its kind, and she started CuraCore Vet. CuraCore Vet offers a comprehensive curriculum in integrative medicine with a rational, evidence-supported foundation. And the courses they have include medical acupuncture, photomedicine, botanical medicine, medical massage, and integrative rehabilitation. So you can find out more about CuraCore Vet at curacore.org, and you can also see them at this year's Vet Rehab Summit on the 31st of August. So over to the chat with Anae and Narda.
Hi, everyone, and welcome. Hi, Narda. Thank you for joining me.
Thanks, Anae. Great to be here again.
Awesome. So we have Narda Robertson joining us from CuraCore Vet. So Narda, will you please introduce yourself? Tell us a little bit more about your interest in today's subject, the conservative management of IVDD.
Well, thanks. Yes. So I'm an osteopathic physician and a veterinarian. And when I was in medical school, I strongly considered becoming a neurosurgeon because I've always loved the nervous system. And so I saw some really highly invasive techniques to deal with disc disease and spinal cord injury, from a human surgical perspective. And then I'd always wanted to be a vet. So I went to vet school, got out of CSU in 97, but actually stayed there for 20 years as a faculty member. And just the more that research has accumulated for acupuncture, which I've practiced since the 80s on humans and then animals, and all these other techniques, it brings to bear the issue of needing to update gold standards and standards of care to match where the evidence is and what people need for their animals and the choices that the animals need for effective interventions.
Awesome. Today we're going to be chatting about conservative management of IVDD, but we're going to focus on the research, and we'll just essentially do a bit of a research review as we describe and discuss a couple of research articles. We have about 5 prepped for you today. If you have any questions, please pop them into the comments and we'll answer those and discuss them, bring them into the conversation. We've prepared some simple slides because that's easier to look at than really just overwhelming text-heavy research articles. We're here to make this easier for you guys, not harder. So, okay, let's dive into our first one. Starting off, we're going to be looking at the non-surgical rehabilitation in Dachshunds with T3L3 myelopathy, the prognosis and rates of recurrence. And this one, I think they're all published pretty recently, but I see that I didn't put the dates on here. I'm so sorry, guys. Okay, so this study was a retrospective cohort that looked at the functional outcomes at 12 weeks in 40 Dachshunds with presumed Hansen type 1 IVDD at T3L3 and then treated with non-surgical rehabilitation. Physical rehabilitation protocols varied on patient needs and owner availability, but they included acupuncture, electroacupuncture, therapeutic exercise, gait training, laser, manual therapy, hyperbaric oxygen chamber, PMF, and NMES and TENS. And you can see how those numbers were distributed in this little table. So Narda, in this paper, how are the IVDD dogs diagnosed and assessed? And what is the modified Frankel score?
Right. And I do want to talk about the gold standard and how, non-surgical compares to surgical, because I think that even with this paper, which most of these authors I know very well, we're tackling the idea that we often hear that surgery, whether for cranial cruciate ligament disease or disc disease, is the gold standard. I mean, how many of us haven't heard that when we're in school and then when we're out and we're worried about, like in our region, at least in probably North America, like what is the standard of care that I need to meet so that I am comporting with what's expected of me as a veterinarian or whatever else it is. And so I just wanted to mention that this is a great paper because it is providing evidence supporting a non-surgical approach. Within the paper, there is some mention, well, if surgery wasn't available or, if the clients weren't able to do it. So it's like there's always that little thing about, well, what if I don't mention surgery? So just in general, as we start out here, what I encourage my students to talk about and what I would do in clinical practice is here's the evidence, hence we're covering evidence. Here's the evidence for surgery. Here's the evidence for non-surgical approaches, and maybe you go into more detail or less, but it's like, what are the pros and cons? What are the risks and benefits? And if we look at that, I hope what people come away with from this talk is look at all the benefits that non-surgical approaches provide for the animal as a whole, and then for different aspects of, their tissue healing, their pain control, the amount of additional damage that might happen. So this whole notion of gold standard, I mean, no country even follows the gold standard now with respect to gold and currency. And in plastic surgery, they're saying, like, how can you even say there's a gold standard for surgery? Because there are so many different types of techniques, so many different patients with various presentations and goals, that it's really outdated and inappropriate to rely on this term gold standard anymore. So I'm in that camp. Anyway, so what was your question again? What are we doing with this paper and what did they look at?
Yeah, so how did they assess, how did they diagnose and assess these guys, and what is the modified Frankel score that they used?
Right. That's right. So now this is a retrospective study. So that's one of the limitations that we're going to see with some of these other papers too, that you're deriving your data from evidence included in records that you're taking out. And with this group, they had worked at the same clinic for quite a while. So in order to provide information about their levels of dysfunction and impact from a putative intervertebral disc disease problem, you have to have certain aspects of like neurologic findings or pain findings. And so in the paper, they talk about the modified Frankel scale, which is going essentially from normal. Well, they don't include the level of normal. Like I have a less undetailed modified Frankel score, so you can find different ones, but the lower the grade, the lower their neurologic function. So they're going from things like, is there only, so if we start with the one that they had in there, is there only paraspinal hyperesthesia? So, pain or sensitivity on the back. I have a criticism of that because maybe that's myofascial dysfunction. How can we be sure that that's intervertebral disc disease? And then going in with ambulatory paraparesis is the next stage. So 5 is just the paraspinal hyperesthesia, 4 ambulatory paraparesis, or some people look at tetraparesis. Then you go 3 is non-ambulatory paraparesis, 2 paraplegia with intact superficial and deep pain sensation, 1 is paraplegia with absent superficial but intact deep pain sensation. And then grade 0, which you don't want that, paraplegia with absent superficial and deep pain sensation. So with all these different aspects, and there's more in the non-reduced detail version that I was showing you, but it's like, so the practitioner that's evaluating the patient has had to have documented, what level of, pain sensation do they still have? What level of ataxia? So you are reliant on the clinician's records for stuff like this. So that, that is a limitation that we will address. But still, what did the practitioners generally assess? Conscious proprioception and deficits, and like we said, the paraspinal sensitivity or hyperesthesia. And then were they ambulatory? Did they require assistance or not? Different things like that. And then superficial and deep pain. But even though we see the modified Frankel score in a lot of these reports, there's actually a movement from an international perspective, to use the 5 different scales that are out there, because sometimes 0 is the best. In this one, 0 is the worst. So it's very confusing. And it's good that there's an international group looking towards systematizing these scores and testing them for reliability and can they really predict prognosis and all that.
Okay, I love that. Thank you. That was very, very detailed and helpful. All right, if you guys are joining us live, please ask any questions that you have. We are going to just be deep diving into the research. What I wanted to mention, actually, Narda, because you were talking about the retrospective studies, is I personally love retrospective studies because I like that it's clinical information and clinically applicable. Understanding that there are a lower level of evidence, yes, but it's so important for all of us to be really meticulous with our record keeping systems, so that if we have the opportunity to go back into our records and create retrospective studies, we can. It's a possibility. So just an encouragement there. Okay, so in terms of their results, of the 40 dogs that had complete records at the initial evaluation by the rehabilitation service, 4 of them were lacking deep pain perception. So they were that modified Frankel score of 0. Then 4 had deep pain but were lacking superficial nociception, so level 1 or grade 1. 5 dogs had paraplegia with nociception, so level 2. 7 had non-weight bearing, non-ambulatory paraparesis, or 3B, and then 8 dogs had non-weight bearing, non-ambulatory paraparesis, so 3A. 10 dogs had paraparesis and ataxia, and then 2 of them had spinal hyperesthesia only. Of those 40 dogs, 34 of them had a positive outcome at 12 weeks after presentation. The 6 dogs that didn't have a positive outcome, 4 of them had been euthanized and 2 had improved but not yet achieved the functional PET criteria. These 2 dogs continued in their rehabilitation past that 12-week period. Awesome. Heather, thank you so much for being with us and for joining us for the studies. That's great. Okay, so Narda, this is another table that they shared with us. Can you describe what they're talking about here and what are we taking away from this?
Sure. Yes, gladly to. And just to comment on the value of retrospective studies, what I really like also is that you're not artificially inducing spinal cord injury, which kind of breaks my heart. And when they do induce artificial spinal cord injury, especially in rats, they'll like drop a ball bearing on an exposed spinal cord. That is not the direction or method of injury, mechanism of injury that is naturally occurring. So by analyzing the results like these of naturally occurring disc disease in dogs, we're better able to create a translational model, because that's part of this whole international thing. To get better scales is they want to systematize it so they can do this great translational research from humans to dogs, because dogs are great. The naturally occurring disc disease in dogs is a great model without causing pain and trauma unnecessarily in the animals, hardly ever necessary, for humans as well. So it's a One Health kind of thing. So with this figure 1 from that paper, the overall goals is to get the animals continent again. So they were also monitoring, was there fecal or urinary incontinence, to get them to ambulate without assistance, and have no to minimal deficits, maybe mild CP deficits in the hind limbs would be okay, and satisfactory pain management. And so when you look at this is presenting the 40 dogs overall. So if we look at columns where it says the Frankel score 1 through 5, then the total of those numbers, so these are just numbers of dogs. You see on the y-axis number of dogs. If you look at that and you tally them all up, you see there's 13 dogs in number 1, then 8 in number 2, 9 in number 3, 5 in number 4, and 1 in number 5. All those numbers create 36. And so what they found was not 36 out of 40 dogs, or 90%, had improved by at least 1 grade. So they just got to, get 1 higher over the course of treatment, because of course 6, which isn't shown here, is normal. And then if you look at 3, 4, and 5, then that's 15 dogs. So 9, 5, and 1 under 3, 4, and 5. 15 dogs are 37.5% improved by 3 or more grades. So and the 4 dogs didn't improve, and those were getting the euthanasia. So just really relying heavily on the modified Frankel scale. And so, which relies on the records and everything, but at least we're getting numbers and able to compare that to what happens after surgery.
Okay, so their kind of conclusion is that clinicians should strongly consider rehabilitation as a viable treatment alternative when advanced imaging and surgery are not possible. Additionally, including rehabilitation as a component of conservative management may help to decrease the risk of recurrence of neurological signs. So, yay.
Definitely. And what I hear, even across the globe, I mean, where you are right now is across the globe for me, but is it even some schools are too many schools are teaching, with surgery as the gold standard. If you don't do that, like, there is no other option. So this is so important to get the information out and the evidence out, because people and animals and you as practitioners have options, and these are meaningful, effective tools. I do see, when advanced imaging and surgery are not possible, I think that's the next step. Is, do we have to always try to send them to the most advanced imaging and surgery, or can we actually look at it on a level playing field and say, these are the dogs improve, they don't necessarily need surgery, but we're always against that. Oh, they should have surgery. If not, well, okay, you can do an also ran. That's not the case, in my opinion.
And I think that's it. It brings up a really good point, Nada. If you're saying, what about this advanced imaging? It is very cost inhibitory for a lot of owners, and if they want to pursue rehabilitation and they're throwing all of that money into imaging, what is the end value to the patient of the money that they've spent on the imaging? And I I do think there are cases where we should say, all right, let's hold off on the imaging, let's focus on rehabilitation, and then if things don't go according to plan, the patient's not progressing like they should with the prognosis or with the condition that we're assuming it is, then yes, imaging becomes a different conversation. But I mean, what are the numbers in that? Most of the time we are dealing with IVDD. We can assess it. We can assess it functionally. We can look at what is the patient's function, and we can work from that point forward. So I think that it is, for many practitioners, it becomes this debilitating point when we don't have a diagnosis. They don't feel like they can move forward, and it's like a blocking point for them. And that's something for us to think about, because it doesn't have to be.
Totally. And sometimes if they don't examine the whole animal, or you have tunnel vision, it's like, it must be this. You could be missing the cervical, you could be missing something that functionally, a full analysis of that patient with a myofascial pain assessment and watching how they move. My thing, how to see a dog or how to see a cat. It's like, oh, there are problems here and there are problems here. Or this is a Frenchie, a French bulldog, or this is somebody that has so many issues. Like, why are we putting them further at risk? And also, as we see with some of these papers, that getting these neuroprotective non-surgical approaches in early, like acupuncture and laser therapy, to be neuroprotective and help normalize the milieu of the spinal cord. And like, it's vital to start those ASAP, within 48 hours, ideally. So if we're delaying and we're waiting till the MRI and we got to delay, like, that's not helping the animal at all.
All right. So is there anything from this paper that you want to highlight before we move on to the next one?
Well, yeah, I mean, how many dogs improved after merely 12 weeks? And so people should have options. That's the moral, ethical thing. It sometimes could be legal, considering, full informed consent. Some places don't go with informed consent. That's too human-y. It also reinforces the need for a neuroeval. So I tend to think that from my experience and decades of teaching vets, that it's like the neuro exam is often obscure to people. But these techniques, like, they weren't even including like necessarily crossed extensors or whatever. So get the minimal stuff down. You don't have to hop and wheelbarrow and everything. There are minimal things you just need to know to get onto that modified Frankel scale, and then some, ideally, for neurolocalization. So it's within your reach. Don't be afraid of it.
Yeah, I love that. Okay, I love that. Awesome. So our next paper is the evaluation of the success of medical management for presumptive thoracolumbar intervertebral disc herniation in dogs, a 2007 paper. I put that in this time. Okay, so this was, again, a retrospective case series that included 223 dogs with suspected thoracolumbar disc herniation that were medically managed. Owner questionnaires were used to collect information on success of therapy, recurrence of clinical signs, and quality of life. All right. In the study, 83% of dogs were ambulatory at the initial evaluation. Successful treatment was reported for 54.7% of dogs. 30.9% had a recurrence of clinical signs. 14.1% classified as therapeutic failures. Glucocorticoid administration was negatively associated with success and quality of life scores. The duration of cage rest was not significantly associated with success or quality of life, and non-ambulatory dogs were more likely to have lower quality of life scores. All right. Okay. So what do you think, Narda? What is the significance of this paper? What should we be looking at here?
So what are my impressions? Well, what are the limitations in clinical significance? So with this study, I mean, the first thing that pops out to me is the duration of cage rest was not significantly associated with success or quality of life. I hate cage rest. I think it's hard on animals. They're going mental, so to speak. They're having nervous breakdowns in there sometimes, even after surgery, like at CSU. Sometimes they'd injure themselves all over again and need another surgery because they were so bonkers. And so, yes, we can restrain their activity. I mean, they shouldn't be chasing squirrels and all this stuff. But cage rest, the physiological problem with that is they can have further disc degeneration and maybe joint degeneration because they are not weight bearing enough. So there's the psychological trauma. There's, if we're saying that movement or motion is lotion and we want all this stuff, then let's institute a really good and safe rehab and integrative medicine protocol from the outset and talk to the pet parents about, don't let them do this, that, or the other, or take away, possible problems. But in their research, when they looked at this and they did the review, they found, anywhere from 6 weeks of cage rest. I mean, it was very variable. And that's how they came up with this thing, not significantly associated. So I think that's a big, big point because we still see it being recommended. And I always like to ask, where's your evidence? There is none. And one of the limitations that they mentioned was that they didn't have a ton of or enough severely affected animals. So there was a small number there. And so it could have been underpowered. But then they said, if I can read my writing, the lack of correlation between neuroscore and success may also indicate that some severely affected dogs that didn't have surgery did well with medical input. And so everybody's still kind of dancing around could non-surgical methods actually be good or better? So there is that in there. The glucocorticoid administration issue is interesting because I'm kind of always welcoming steroids, but they were talking about, does it change, the sort of tissue environment to a negative extent? Or how does that balance with the anti-inflammatory effect in it? And because we don't want a big swollen spinal cord getting, trapped within that bony canal, and then that causes neurocompromise too. Oh, and then they had talked about this recurrence rate, because that's something that in my experience lecturing and having neurosurgeons in the audience or orthopedic surgeons, and anyway, we have a good time when that happens. So they'll say, well, that there's less recurrence when you have surgery. I debate that because you have created an unstable spine going in there, moving the muscles, interrupting the mechanoreceptor input that stabilizes the spine and protects it. But also because if you have recurrence, when we look at, I mentioned on the modified Frankel score, the first thing that takes you down from normal is spinal hyperesthesia, paraspinal hyperesthesia. And so is it really fair to say that there was a therapeutic failure if they got some more back pain? I mean, who of us doesn't experience a twinge somewhere during the day, especially if you had disc disease before or whatever? So it's it's over counting maybe at things as a recurrence when it was a little bit of a spasm, but they went with the 30.9% just because they were trying to be conservative and not, bias it towards betterness.
Okay. All right. So yeah, I mean, let's talk a little bit more about recurrence, because as you say, there's what is happening when we're, having that surgical intervention, and it's not just the initial damage that is done, if I can put it that way, to the surrounding structures and to the spine itself, that could increase the risk of recurrence later, or is weakening that spine. But just the kind of focus and progression of rehabilitation, right? If we're rehabilitating post-surgery, it's a lot more protective. Whereas when we're looking at conservative management, there's more of a focus on strengthening, building up functional core strength, right? We're looking at more of a mobility-focused functional approach, and could that be, preventing recurrence or reducing the risk of recurrence? So I think we do need some studies that are specifically looking at that relationship.
Definitely.
Okay. So what would you say is the clinical significance of these results? What should we be taking back with us from here?
That animals could improve without surgery, and why are we doing cage rest? Why is anybody doing cage rest still? Sorry. Highly opinionated on that one. I mean,
In
most things. Go ahead.
Yeah, in terms of cage rest, are you doing something as an alternative to kind of protect in that initial phase of healing? So I know there are like the wiggleless back braces. Are you doing anything like that, or how are you managing your patients?
I mean, with limiting them in a room or so, I mean, taking them out when they're on a lead of some sort, if it's a neck disc, I mean, we don't want to worsen that but just a controlled environment where they can still bear weight. So that's important for joints and for the disc health, and spinal cord health. I mean, and like we've seen animals that have, um, been unattended to, that are in cage rest, and then it never received rehab or anything, and they start losing the ability to walk. They lose muscle mass as well as, the weight-bearing health benefits for joints and discs. But when you have an interruption in the neural connectivity that should be going through the spinal cord, and you're putting them in a box and they're just kind of laying, like, their functional reconnectivity is getting screwed up. And so, like there's that old adage, nerves that fire together wire together. Let's get them into a rational, safe, modified, patient tailored rehab kind of thing where they are weight bearing, where they're doing it correctly, so that we're causing those nerves to fire appropriately together so that they rewire together. And that is going to be stimulatory to the recovery.
Okay, so the next paper we're looking at is the comparison of decompressive surgery, electroacupuncture, and decompressive surgery followed by electroacupuncture for the treatment of dogs with intervertebral disc disease with a long-standing severe neurological deficit. So we're looking at dogs that have gone over that 48-hour, acute injury mark, and then start treatment of either surgery or electroacupuncture. So this is very interesting. Okay, so this is a retrospective case series and a prospective clinical trial including 40 dogs with severe neurological deficits for more than 48 hours attributed to IVDD. Electroacupuncture was significantly more. No, wait, did I just give it away? Narda, did you need to say something here on this first slide?
Not that much, except, it is from 2010. And I know that at CSU, we started using laser at 2009. So around then. And now, so just like, even to keep in mind that when we're looking at something like electroacupuncture and surgery and all that today's integrative rehab environment will have so many additional modalities to use that this is like one little piece, and the data that we see here can be like amplified, and it's just there's so many things. Harder to do research when you have 10 different therapies you're doing, but still, we see the clinical improvement. Anyway, that's my main thing, I think, on that.
Can you tell us what currently in our teachings, in our literature, what is the expected outcome for deep pain negative dogs, especially when they're going past that 48-hour mark?
I mean, in general, it's considered poor with the ones we saw in the non-surgical, the first paper. I think that all the severely affected ones did not improve enough. In reality, or do you want to do that comment?
Oh, hi. Hi, Heather. All right, so it is limiting what we can reply, but I would say as an RVT and GP, the prognosis, if there's no deep pain response, is usually poor. Yeah, that's exactly it. We're usually leaning to a pretty poor prognosis for those guys.
Yeah, and so taking that into account too, that's the prevailing idea. One particular case stands out to me that I had treated at CSU, where I was referred a dog, adoption, deep pain negative. They thought he had ascending, descending myelomalacia, this, that, and the other. They recommended euthanasia. And the client said, no, I'm going to try acupuncture first, and then I want physical therapy. And when I examined the dog, I mean, I inserted a couple of acupuncture needles in the paw, and the dog looked around, and I was just amazed. And I looked at the client. It's like, Charlie is feeling this. And so I think that, again, we are cultivated to have low expectations, and maybe in your rehab practices, you have seen that it is more challenging, but this dog, like I did acupuncture. I sent him to the clinic where those guys that did the first paper, they had nearby rehab and acupuncture and emergency clinic, and they did rehab, and he'd come down from Wyoming, spend the day, do diverse things. And even though it started with spinal walking, I mean, that was enough, and he could get along, and then he kept on improving, and they did underwater treadmill and laser and acupuncture and everything. I think because we are cultivated to assume, oh no, there's nothing and you got to do surgery right away, that if that doesn't happen, then they're like, well, there's probably no hope. We don't even give it a try. And that's the significance of the paper we just looked at, that said, even though the study was underpowered with enough of really severely affected dogs, the medical approach showed some value. So I think we should give clients the option to pursue this and manage their expectations. But you might find things that somebody somewhere was squishing a toe with, forceps or hemostats or whatever, didn't see the animal react. Maybe that is not the full story. And maybe there are other pathways that we can make use of. Because I have treated a number of dogs deep pain negative, even after a couple of years, and there's stuff you can still stimulate. So I think our whole kind of ethos and mindset needs an update.
It also highlights that a successful outcome isn't the same thing. It depends on, there's not just one successful outcome, is what I'm trying to say. It depends on the home environment and the capabilities of the owner and their wishes as well. And so there are different things that can, Okay, so let's see. Okay, so hold on, I have to find my notes. Sorry, guys.
I'm supposed to discuss the information in this.
You are. Thank you. I don't have notes.
Yeah. Essentially, they kind of looked at before and after the treatment, and so this is where deep pain comes in, because it's like, well, did they improve or not? So number of dogs with IVDD with longstanding that had lack of deep pain perception before, and then rechecked them at 6 months after the treatment on that row. And so you see that with surgery, which is DSX, did not change. With electroacupuncture alone, EAP, there was some change. So when the lack of deep pain perception goes down, then that's an improvement. So they were gaining the deep pain perception. And then surgery plus electroacupuncture, I think it was after, you see the before and after, and that was a significant difference. So, some animals you'll see, or some studies you'll see it combined with surgery, some places alone. When I looked at this and I saw the two bottom categories, it's like, well, how different is 10/19? How different are they? And so I did the percentages, and 10/19 is 52% versus after 4/19 is 21%. So, kind of like half. But the before and after for the last row, 8/11, granted, fewer numbers, but that's 72% versus 27%. So I can see where that was a significant difference.
So let's look at the next one. Are you discussing this one as well?
Yeah, this is even more complicated. Thank you, Renee. I think that the ability to look at this, so neurologic improvement at 6 months after initiation of treatment. So were they unchanged or was there improvement? And they were looking at the myelopathy score, which I didn't think was very well defined in this paper. So we still don't know. But what happens is, so if you go across the row, so you see the little lowercase numbers and uppercase numbers. If you compare the lowercase numbers, so that's where there's a significant difference. So under surgery, DSX, and unchanged, so we have a little a there. The next little a along that row, so between surgery alone with little a and surgery plus EAP in that far right same row, that was a significant difference, that how they were unchanged or whatever. And then electroacupuncture versus surgery with electroacupuncture, there's a little b, and that was significantly different, between the two. The next row, the improvement, surgery versus, so little a, and then that far right column. So that was a significant difference. So there were more improvements with surgery and electroacupuncture. And then you look at the little b, between electroacupuncture and then electroacupuncture with surgery. So those two were significantly different as well. So essentially, electroacupuncture with surgery, that's just another analysis of the data. If you look at the groups with the large A and the large B, so the A's and B's are a little confusing, but it was significant difference within a column, so that electroacupuncture and the improvement. So I think it was a significant change when you had electroacupuncture between adding electroacupuncture and not. That one I'm kind of like a little bit confused, but no significant difference. I don't know. I think I wrote down some of the summaries. It was in the paper, but I'm still a little bit perplexed by this table, to tell you the truth.
I love how, it is completely possible to express data in a, understandable way.
Yeah.
It doesn't have to be complicated. And yet we have so many papers where you just, you're trying to make sense of the data and you're just like, what? And I sometimes feel like I have to interpret the data from the beginning to the end in some papers, because they just are not explaining it in a way that makes any sense. So I have to figure it out for myself. That's
Right.
very frustrating in a paper. Yeah.
It is. I think it would have been clearer if they were between capital A and the B. So I can see where they're using capital letters as the superscript in the group for electroacupuncture, that middle group. I can see where, well, the ones that improved were 15/19 versus the one that were unchanged were 4/19. So that was a significant difference. Versus you look at the surgery group and it's between 6 and 4 out of 10. That doesn't seem so significant. If you look at, there's an A for surgery plus electroacupuncture in unchanged. So fewer of them were unchanged, than 8 out of 11. So that was a significant difference. So you see that once they went on for 6 months and were reassessed, that both groups that received electroacupuncture, there were more in the improvement group than in the unchanged group, versus the poor little surgery people. They were kind of about the same.
Okay.
With a little,
right.
with one more, with more unchanged than improved. In fact,
I didn't do a little summary slide for this one. All right, that's fine.
Yeah.
Okay, so essentially, electroacupuncture was significantly more successful in achieving a positive outcome than decompressive surgery or decompressive surgery with electroacupuncture. That's kind of my take home.
Yeah, I think it matters what you were looking at. I think, because I think that previous table was with surgery and electroacupuncture was a little bit better, but the numbers aren't super high. And when we talk about, why aren't these replicated? It's a lot. A, it's a lot of work, and so somebody has to want to do it. B, there's not a surgical or pharmaceutical company paying for people to do this. So, and then C, you have to have enough consistency in your medical records to be able to retrospectively analyze things and have similarity. So there are groups. Yeah, we do need more replications in a way, but I mean, we still an impressive amount of studies, in my opinion.
Yeah. So I kind of read this initially, and my first thought was, well, this is a far better outcome for these deep pain negative dogs when electroacupuncture is incorporated than we've been led to expect with any other approach. So if that is if this is true, and if this is, a finding that we can take back into clinical practice, because I do strongly believe that you can't really make clinical decisions based off of one research article. You do need more studies. So, which is why I have a question: why hasn't this been replicated? Why are we not seeing more studies focusing on electroacupuncture, especially in this group of IVDD dogs? Because if we can improve the prognosis significantly, then surely that is something that we want to look at. So is it kind of coming back to what you said earlier, that these dogs are not really given a chance? If they're deep pain negative, are the owners presented with opportunities to treat or to pursue treatment, or is the first recommendation that they should be euthanized? That there aren't any good treatment options available and their prognosis is too poor to pursue? Because for sure, if that is the picture that is being brought into clinical practice, then how many dogs do we have to work with that are deep pain negative? That number would be quite small. And so is it realistic to pursue studies? How do we do that? So that's kind of the question that comes up for me when I read this article. I find it really exciting, but also, what now? What do we do with that?
Well, an interesting thing too is, like, when I've been doing, like, I wrote the acupuncture chapter for the new Millicent Levine book, so we're going to have acupuncture, hopefully, unless they decide they don't like me or something. But anyway, hope they don't. But anyway, just reviewing the research as it is now, like, there are many more. This is an old study in retrospect, and I forget when it was, a 2010 or something. But there's so much more coming out, and we know the mechanism of injury, and there are no randomized controlled double-blind clinical trials in surgery. So let's get that out there. And, with now photobiomodulation therapy, like Heather had mentioned, and adding that in, it's like, why would we even want to not add laser therapy when that has such a strong thing too? And so just the paradigm should be, okay, let's do integrative rehab with, let's say, 3 to 5 therapies that are safe, and we know the mechanisms of action, all this stuff, versus surgery, I guess, if they have to. But this same group that had published that first study, that's where I got my information on our clinical trial for snake envenomation. And when we were talking to, like, they had been on their way to do a study, and it was like within the first year, the dogs that had received rapid, good laser therapy for their snake envenomation, they did so much better during that first year. It's like they decided this has to be standard of care right now. It's an ethical challenge. So we get back to the VRS. Ethical challenge when you see how much these improve, to not offer this. Like, why would I? That would be heartbreaking to me. Oh, I have to do my study, so I have to give you like a sham or something treatment. So I think the standard of care, from my opinion, for dogs presenting with IVDD would not anymore be just electroacupuncture, though that is significant and central. It would be, laser, acupuncture, and therapeutic exercise at the bare minimum.
I love that. So if we are if we're thinking about the level of evidence, so this is a 2010 study. It is a retrospective case series, so it isn't the strongest level of evidence, right? And we haven't had any additional studies that have looked at electroacupuncture in this kind of group of dogs. So the next best thing we have is our own clinical practice results and what we're seeing in practice. So Narda, for you, do you get a positive prognosis, or do you have a better prognosis in these deep pain negative dogs when you're approaching them from, and like you said, it would be electroacupuncture, photobiomodulation, and at the minimum rehab exercises? What kind of prognosis are you seeing? Is that reflective of our current beliefs or understanding, or is there more of a chance than we're potentially giving these dogs?
Yeah, well, I'd say that, over the course of my work, I've probably treated like 3 to 4 deep pain negative dogs. So, I don't have a large N either. But what I have seen consistently is that if we can provoke even a withdrawal reflex, so there are stages, and so maybe they're deep pain negative, or maybe however you're going to analyze it. Let's say there's a consensus, okay, they're not responding to that. But can I get the nervous system, even with unconscious withdrawal? Can I even get reflexes to go through the spinal cord? I just want to get some action potentials. And so that's the thing, is that with acupuncture, we can specifically target like these peripheral nerves. And even if it's not going to go past the spinal cord yet, because of maybe glial scarring and all that, which acupuncture and laser therapy can help to avoid, we can at least make circuits through the spinal cord and promote that. So my initial goal might just be like, let's do some spinal walking, or let's help things along while they are in maybe a cart. And so we're protecting like their structure, letting them get around, but still working with the nervous system to see how much capacity there is to heal. Because not every dog that like, what is causing the deep pain negative? How much trauma within the spinal cord? Like, what kind of real estate have they lost with neurologic connections? That's not they're going to be very different. And so the fact that I have been able to, as well as my colleagues, to start to get them to even reflexively spinal walk, I mean, that's going to restore function to a degree. And also making use of the nerves from the tail. The tail is a great one to show clients if they have a flaccid tail, they can't move. You stick some acupuncture needles in there where even the limbs don't move. You can start to get a little bit of a wag. Show the clients, I can put it on each side of the tail and make it wag this way, wag that way. So, this is an unexplored area, but if you know enough about neuroanatomy and the effects of what these treatments are, you just employ these, and with a spirit of, let's see what we can do to help. Let's see how much healing potential this patient has that we can unlock and make the best use of, rather than, oh, there's no hope. Yeah, you're never going to walk again. I mean, it's a mindset that is present in other fields, but is for some reason so dominated by surgeons and surgery in veterinary medicine that it's this tunnel vision, and they have to go to the surgeon, or else I'm not practicing standard of care. I'm not offering them the gold standard. Like, let's start questioning that, because I'd be happy to debate surgeons on the evidence and ethics of it, and the potential for what we can do for animals. And we really should be offering people options.
Awesome. Narda, thank you so much for that. So we are exploring topics like this because they have that kind of ethical connection. What are we offering? And that ethical connection is coming back to our theme for the Vet Rehab Summit this year. And so I hope that discussing topics like this helps you to understand that we are facing ethical dilemmas within vet rehab, and they are much more prevalent than we might first realize when the topic is thrown at us. When, I think for a lot of us, the first time you hear the ethical dilemmas that vet rehabbers face, you're like, wait, what? Because we're not dealing with a lot of the more hardcore things that veterinarians are. But there are a lot of things. And like this, the passion that we can see in you, Narda, for this conservative management, for the options that are available to pet parents, to me, that is really the core of it. Because when we find these injustices that we feel, we are the advocates for these animals. We are their voice. And many owners don't know. They don't have the information. We do. And so how are we speaking up for them? How are we making that available? How are we advocating for the animals, especially in the areas that we are most passionate about? And I highlight that because for each of us, that will be a little bit different. Something else will lie close to our heart. And we have a role to play in this world and in this space. So let's fill that space. Let's find the thing that we're most passionate about, and let's stand in that space. Let's stand in the gap for our patients, and let's find ways to make the world a better place from the perspective of we're working together, we're here as a team. So with that, join us at the Vet Rehab Summit this year. It's on the 31st of August. We're going to be exploring some great topics. It's going to be an amazing day. Join us live. Online Pet Health members have free access, so that's the way to join, guys. But if you don't want to be a member, that's fine. And there is also a free ticket available where you'll be able to access one webinar during the course of the day, but you will be able to access a lot of the other activities and the site that we have set up for the day. So feel free to join us. We would love to have you guys there. Narda, thank you so much for your time today, for your expertise. This was an amazing discussion.
I had a lot of fun. Thank you.
Bye, guys.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. A big thanks to our sponsor, CuraCore. Their sponsorship allows us to be able to give this podcast to you for free. So please go and check them out at curacore.org. Don't forget to bookmark the next Vet Rehab Summit. It's on Saturday, the 31st of August, 2024. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehab community. Online Pet Health members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com.